My regards to all chairpersons and my many thanks to the organizers of SPARC 2021 for providing me with this opportunity to interact with you all. And so I'll start with the session. All the good questions are always a backbone of the evidence-based medicine. And with respect to our topic today, the issue is all the good questions which should come, like, should I give this patient more fluids? Will this patient improve hemodynamically in response to the fluids? Does my fluid bolus likely to augment cardiac output and thereby any improvement in tissue perfusion? Does my patient really needs fluid? How much and how long? So these questions need to be addressed, and for that we will continue with discussion of the topic. In more than 50% of critically ill hypotensive patients, fluid boluses usually fail to augment the perfusion. Hypovolemia is not the only cause for hypotension, whereas under-resuscitation results in inadequate organ perfusion. Accumulating data suggests that over-resuscitation increases the morbidity and mortality of critically ill patients. And we will see that in our next few slides how. So how do we define what is volume responsiveness? Fluid responsive means a response to a fluid challenge by improvement in stroke volume or cardiac output by at least 10%. In fact, specifically by increase in stroke volume, because sometimes the cardiac output still can be increased by increasing heart rate. The static variables like the central venous pressure, pulmonary artery occlusion pressure, right ventricular end-diastolic volume, left ventricular end-diastolic volume, these all have limited predictive value on fluid responsiveness in increasing the cardiac output in a patient with shock. This may primarily be due to the fact that the ability of the heart to respond to preload does not depend on the absolute value of ventricular volume, but on how that volume is located on the Frank-Starling curve for that heart. Specifically, the heart must be on the steep portion of the Frank-Starling curve to increase the cardiac output in response to any preload expansion. We see on the left side of the screen, when the stroke volume is plotted against the ventricular preload, we can observe that when the heart is lying on the steep portion of this Frank-Starling curve, for a particular increase in preload, we get a very appreciable increase in the stroke volume. Whereas when it is on the flatter portion of the curve, for the same increase in the preload, we do not get an appreciable increase in the stroke volume. And when the heart lies in the steep portion, it is considered to be fluid responsive. When it lies on the flatter portion of the Frank-Starling curve, it is known as no fluid response to the volume expulsion or fluid unresponsive heart. Here we see during the two variables, stroke volume versus ventricular preload, see the curve of the normal heart. And now here in this, we see the curve of the failing heart. And in between these two, we see various curves. So what does it signify? That a particular increase on preload, whereas it may have an appreciable increase in the normal heart, but not that expected increase in the failing heart. And this is what we have to understand with regard to fluid responsiveness in response to preload or rather preload dependency of the heart. So these are interchangeable terms. So here we see the preload dependence of the normal heart and preload independence of the failing heart. When we administer fluid in a heart which has into the flatter or the plateau portion of the Frank-Starling curve and further incremental doses of preload expansion can actually lead to impaired myocardial performance, as seen by this diagram. So the static indices are pressometric. Indices are central venous pressure and pulmonary occlusion pressure, whereas the volumetric indices are right ventricular and left ventricular end diastolic volume and global end diastolic volume and intrathoracic blood volume. CVP, on the basis of CVP alone, large number of studies fail to discriminate between the fluid responders and non-responders. Only extreme values of CVP are of some clinical significance. Degree of hypovolemia does not correlate with CVP. Factors which increase intramural and transmural pressures can affect the central venous pressure, like pump failure, valvular diseases, dysrhythmias, positive pressure ventilation, peak end expiratory pressure, pneumothorax, asthma, etc. Of course, it needs invasive line too. More than 100 studies have been published to date that have demonstrated no relationship between the CVP and fluid responsiveness in various clinical settings. For long, pulmonary artery occlusion pressure has been considered as the gold standard for determination of LV preload. This also needs invasive pulmonary artery catheter, but the limitation is that it has been found or observed that it is no better than CVP in predicting preload responsiveness. Recent studies have clearly demonstrated that pulmonary artery occlusion pressure is a poor predictor of volume responsiveness. It suffers many of the limitations of the central venous pressure. So why dynamic assessment? More than 50% of ICU patients suffer from iatrogenic harm with respect to fluids, interventions, polypharmacy, rationale, antibiotics. More evident clinical signs and symptoms are seen after only established flow rate organ dysfunction, which might bring poor clinical outcomes, like fluid overload, gut and organ edema, etc. In the early course of organ dysfunction, clinical signs and symptoms are subclinical and very subtle. This emphasizes the need for constant and dynamic assessment to find optimal goal-directed fluid therapy. And this is why we need dynamic assessment. Fluid resuscitation is based on downstream parameters of microcirculation. When they are based alone on these parameters like serum lactate or central venous oxygen saturation, it may be harmful. Why? Because normalization or decay to baseline of these parameters happen long after actual organ recovery happened. And during that time, if you continue with fluid resuscitation to normalize these parameters, it might result in tissue edema and organ dysfunction. Thus, dynamic assessment of indices of hemodynamics gained momentum because it questions, does this patient really need fluid before actual fluid is given? Is this patient fluid responsive and fall in steep portion of the ventricular contraction? How much fluid needs to be given and how long should it be given? So this is why we need dynamic assessment, because dynamic assessment is able to answer these queries. Dynamic measures of intravascular volume using heart-lung interactions to assess fluid responsiveness is called dynamic method of assessment. We will discuss the heart-lung interactions in detail to understand this concept. It can be in mechanically ventilated patient or it can be in spontaneously breathing patient. Remember that. One aspect mechanically ventilated and then the other spontaneously breathing patient. How do we classify the dynamic indices? First group consists of indices which are based on mechanical ventilation induced variations of stroke volume and stroke volume derived hemodynamic parameters like stroke volume variation, pulse pressure variation, aortic flow variation. These are determined by mechanical ventilation induced cyclic variation in intrathoracic pressure. Second group consists of indices based on mechanical ventilation induced variations of non-stroke volume derived parameters, namely vena cava diameter, ventricular pre-ejection period, etc. Third group consists of indices which are based on preload redistribution maneuvers like passive leg raising. Let us deal one by one. Physiological rationale of dynamic indices of group A, that is heart-lung interactions. Useful concepts in understanding why dynamic indices can predict fluid responsiveness. Effects of mechanical ventilation of left and right ventricular stroke volume. Now let us understand this very clearly. Unless until we are able to appreciate and understand the heart-lung interactions very well during inspiration, during expiration, in a mechanically ventilated patient, in a spontaneously breathing patient, unless until we appreciate how these heart-lung interactions affect the left side of the heart, how they affect the right side of the heart, we will not be able to appreciate the dynamic indices very well. So it is very, very, very important that all these concepts are ingrained in you very well so that you are able to appreciate and understand and answer the questions based on advanced hemodynamic monitoring or relatively to the dynamic indices. It is very important. That's why at various points it is possible during this course of 3 lectures, I may be repeating these concepts in one way or other whenever we are dealing with a relevant topic, so that your concepts are very clear, and it needs to be very clear. During mechanical inspiration, right ventricular stroke volume decreases. At the same time, the left ventricular stroke volume increases. Now, opposite phenomenon is observed during expiration. Physiologically observed in all patients, but they are much wider in hypovolemic states. Thus, their amplitude, that is the swing in these variables, which are a function of the heart-lung interactions, they are predictive of fluid responsiveness. And because they happen more, the amplitude of that variation happens to be exaggerated during hypovolemic states, we can use these indices to predict the fluid responsiveness. Mechanical insufflation decreases the preload and increases the afterload of the right ventricle. How is it explained? A reduction of RV preload is primarily due to decrease in the venous return pressure gradient that is related in the inspiratory increase in pleural pressure. Whenever there is increase in intrapleural pressure, the venous return to the right side of the heart decreases due to the pressure gradient. Now, increase of RV afterload, which is related to the inspiratory increase in transpulmonary pressure. Why? How we explain? Small perialveolar vessels, they are compressed, increasing the resistance to the blood flow. So, during inspiration, when there is an increase in intrapleural pressure, that pressure of increased intrathoracic pressure is conducted to the pulmonary artery pressure or the small perialveolar vessels, which are compressed, causing increase in the resistance and leading to an increase in the RV afterload. So the RV preload is reduced due to decreased venous return, and RV afterload is increased, leading to a total reduction in the RV outflow. So, or RV stroke volume. Now this is minimum, that is the RV stroke volume, then because of this phenomenon is minimum at the end of the inspiratory period or at the peak of the inspiration, you can say, or at the end of the inspiratory period. It's a cyclical, and then during expiration the reverse will happen. So during mechanical inspiration, the left ventricular stroke volume increases, right ventricular stroke volume decreases, but the left ventricular stroke volume increases, resulting in delta up, that is the inspiratory increase of systolic arterial pressure. Left ventricular stroke volume increases, resulting in increase in systolic arterial pressure. The change or the fluctuation or the exaggerated increase in systolic arterial pressure is called the delta, which we'll discuss in detail again. Inspiratory increase of left ventricular stroke volume, how do we explain that? increase in transpulmonary pressure. During mechanical inflation, it exerts a squeezing effect on the pulmonary capillary blood, which is emptied into the left atrium, which increases the LV preload, right? It increases the LV preload because the blood flow more in the LA flows into the LV, so the preload of LV is increased. And a decrease in LV afterload. How? Whenever ITP increases, intrathoracic pressure increases, LV transmural pressure is reduced. So LV afterload is reflected as LV wall stress. LV wall stress is equal to transmural pressure into LV radius. So whenever transmural pressure is reduced, which is multiplied by LV radius, ultimately the LV wall stress or the LV afterload is reduced. In this respect, remember this, in this respect, the mechanical inspiration can be compared to a LV assisting device in situations where LV contractility is reduced. We will further discuss with example. What happens during inspiration? In a mechanically ventilated patient, when there is positive intrapleural pressure, the difference between the aortic pressure and the intrapleural pressure, what we call as transmural transaortic pressure, which is the one which signifies the afterload to LV, that decreases. The transmural transaortic pressure, which signifies the LV afterload, this decreases. During inspiration, it decreases. During expiration, it increases. Say, for example, during expiration, the aortic pressure is 100 millimeter mercury. Intrapleural pressure during expiration is minus 10 millimeter mercury. So transmural pressure would be 100 minus 10 is equal to 100 plus 10 is equal to 110 millimeter mercury. So 110 millimeter mercury would be the afterload to the LV. Now during inspiration, aortic pressure same 100 millimeter mercury. Intrapleural pressure is plus 10 millimeter mercury because of the increased intrathoracic pressure or positive intrapleural pressure. So transmural aortic pressure would be 100 minus 10 millimeter mercury, which is 90 millimeter mercury. So afterload reduction during inspiration, again remember, during inspiration in a mechanically ventilated pressure would be 110 minus 90, that is 20 millimeter mercury. So afterload reduction is 20 millimeter mercury. So this is how we understand that there is an afterload reduction of LV during inspiration and after preload increase of LV during inspiration by squeezing of pulmonary veins. This is how there is an improved stroke volume or increased LV stroke volume during inspiration. So during mechanical expiration, opposite hemodynamic events occur. The right ventricular stroke volume increases because venous return increases during expiration and RV afterload decreases. And the left ventricular stroke volume decreases during expiration, which is responsible for delta down or the expiratory reduction in systolic arterial pressure. So this is the influence of volemic state on heart-lung interaction and how the volemic state will have this influence on interactions. Let's see one by one. If delta down, the systolic pressure variation, right? The pulse pressure variation and the stroke volume variation, they are enhanced. The variation is enhanced when in delta down. When in delta down, these variations are enhanced. They indicate a state of fluid responsiveness. In hypovolemic patients, the SVC, the superior vena cava, collapses on mechanical infusion, determining huge oscillations in the right ventricular stroke volume and left ventricular stroke volume and arterial pressure. After adequate infusion, fluid infusion, the above response is abolished, leading to increase in the cardiac output. So it signifies that whenever there is a delta down, when these variations are enhanced, that indicates a state of fluid responsiveness. You give fluid, the delta down response is abolished. And at the same time, we see that there is an improvement in the cardiac output. So pulse pressure variation derived from analysis of the arterial waveform, stroke volume variation, which is derived from pulse contour analysis. Remember these terms. That's why I marked that in red. The technology is in red. The PPV uses the technology of arterial waveform, and the stroke volume variation uses the technology for pulse contour analysis, which we can get from the PICO monitors. And the variation of the amplitude, so this stroke volume variation and the variation of the amplitude of the pulse oximeter plethysmographic waveform, they are demonstrated to be highly predictive of fluid responsiveness. These are all dynamic indices: PPV, SVV, oximeter plethysmographic waveform changes. They are all dynamic indices, and so we use them to predict the fluid responsiveness. Again, remember the term. The predictiveness of fluid responsiveness means probability. It is just that signifies that, okay, it is probable that infusion of fluid will help the heart improve the cardiac output. It does not mean fluid response means increase in cardiac output of at least 10% or stroke volume of at least 10% by infusion of fluid. That is fluid response. But fluid responsiveness is probability that the heart may respond with increasing the stroke volume on volume expansion. We have already observed preload dependence of ventricle only in the steep portion of the Frank-Starling curve, which is dependent on ventricular contractility. If mechanical ventilation induced preload variation causes wide oscillations in stroke volume and arterial pressure, this suggests that both the ventricles are working on the steep portion of Frank-Starling curve and will presumably increase stroke volume and thus the cardiac output in response to volume expansion. The inspiratory reduction in RV ejection leads to a decrease in LV filling after a phase lag of 2 to 3 heartbeats because of the long blood pulmonary transit time. Thus, the LV preload reduction may induce a decrease in LV stroke volume, which is at its minimum during expiratory period, when conventional mechanical ventilation is used. The cyclic changes in RV and LV stroke volume are greater when the ventricles operate again on the steep portion of the rather than the flat portion of the Frank-Starling curve. The magnitude of the respiratory changes in LV stroke volume is an indicator of biventricular preload dependence. With remarkable consistency, a variation of greater than 12 to 13% has been reported to be highly predictive of volume responsiveness. Multiple times I am repeating the same concept so that it is ingrained. D. Baker and colleagues evaluated the influence of tidal volume on the ability of the PPV to predict fluid responsiveness. For accuracy, reproducibility, and consistency, they suggested that the tidal volume be increased to 8 to 10 ml per kg ideal body weight before and after a fluid challenge. This is for practical application. Which non-invasive technique we can use? The pulse oximeter plethysmographic waveform. This differs from the arterial pressure waveform by measuring volume rather than pressure changes in both the arterial and the venous vessels. As an extension of pulse pressure analysis during mechanical ventilation, the dynamic changes in both the peak and the amplitude of the pulse oximeter plethysmographic waveform, this have been used to predict fluid responsiveness. The Pleth variability index is an automated measure of the dynamic change in the perfusion index that occurs during a respiratory cycle. The perfusion index is the infrared pulsatile signal indexed against the non-pulsatile signal and reflects the amplitude of the pulse oximeter waveform. So the Pleth variability index correlates closely with the respiratory induced variation in the plethysmographic and arterial pressure waveform and can predict fluid responsiveness non-invasively in mechanically ventilated patients. So this is a flow diagram, a chart, which is plotted against the background of the mechanical ventilatory cycle. See, during this is the inspiratory phase and the expiratory phase. Here we can see in the inspiratory phase the increase in interpulmonary pressure and increase in transpulmonary pressure, increase in pleural pressure. The increase in pleural pressure leads to decrease in the RV play load and decrease in LV after load. Whereas increase in transpulmonary pressure, it leads to increase in RV after load and leads to increase in LV preload. We have discussed the physiology behind that. So the result of decrease in RV preload and increase in RV after load ultimately leads to decrease in RV stroke volume and increase in LV stroke volume at the peak inspiration period, right? So the pulse pressure is maximum at the end of inspiration. After the blood pulmonary transit time, we get a decrease in LV preload and decrease in LV stroke volume. So here the pulse pressure is minimum during the expiratory period. So these are the systems allowing for monitoring of dynamic parameters of fluid responsiveness. So systolic pressure variation, it can actually be eyeballed accurately also, but pulse pressure variation cannot be eyeballed. It requires some of the monitors which we have mentioned here in this table. We can see Litco and Pulsioflex, like that. Philips interview monitors. Stroke volume variation again requires monitors like Litco, Pulsioflex, Vigilio flow track. It can be used, EV1000 volume view. And Pleth variability index, which can be monitored by Massimo radical and passive like raising, which we will discuss later. It can be demonstrated with esophageal Doppler or Pico Plus or Vigio flow track. So coming to these group A indices, which are based on mechanical ventilation induced variations of stroke volume and stroke volume derived parameters. What is delta down? Is the difference between the apneic and the tele-expiratory systolic arterial pressure. Systolic arterial pressure apnea minus systolic arterial pressure expiration. Delta up is the difference between systolic arterial pressure at inspiration minus the systolic arterial pressure at apnea level. And systolic pressure variation, systolic arterial pressure inspiration minus systolic pressure, arterial pressure expiration. So they require invasive arterial pressure monitoring and dedicated monitors, all three. Pulse pressure variation is PP max minus PP minimum divided by the average of the two multiplied by average. Required invasive arterial pressure monitoring and dedicated monitor. Stroke volume variation similarly SV max minus SV minimum, this is a little misprint here. Then the mean of the two multiplied by 100 requires PICO or LITCO. Peak aortic flow velocity, VPK maximum minus VPK minimum divided by the mean multiplied by 100 requires a trans-esophageal echo. And peak and another we can use is the esophageal Doppler. So let us see. Let's discuss difference between apneic and tele-expiratory systolic arterial pressure is the delta down. And here we can see in this graph, this is the maximum during the inspiration phase, the arterial pressure. So we get, this is the minimum of systolic arterial pressure during expiration. Okay, and the systolic arterial pressure during apnea, this is the expiratory hold. So this is the apnea phase and we get the systolic arterial pressure apnea. So the systolic arterial pressure apnea, this one, minus systolic arterial pressure expiration, this one, that makes the delta down. It needs an arterial waveform and dedicated monitor and has demonstrated the best predictive value for fluid responsiveness. Remember this for your MCQs. And in this same chart, we can see, appreciate the systolic arterial pressure maximum in the inspiration phase minus the systolic arterial pressure of apnea that makes the delta up. So that is the delta up, the difference between SAP inspiration minus SAP apnea. It does not predict the fluid responsiveness. Remember this, delta down is the best predictor of fluid responsiveness. Delta up is not the best predictor of fluid responsiveness. Significant delta up demonstrates that in heart failure states, mechanical insufflation has an enhancing effect on cardiac output. Remember when I had mentioned that it can, in mechanical inflation, can function as a LVAD in heart failure states. This is what I wanted to say. And delta up signifies that if there is a significant delta up demonstrated or observed in any patient on advanced hemodynamic monitoring, we can conclude that mechanical insufflation can have an NCP effect on the cardiac output of this particular failing heart. So we will not guide ourselves with delta up with regard to fluid responsiveness. But in a failing heart, we can decide, okay, yes, this patient will be benefited, so let us continue with the mechanical ventilation till the heart responds or recovers from the failure. Enhancing, why this happens? It happens because of the enhancing LV preload by squeezing the pulmonary capillaries and decreasing the LV workload acting as LVAD. So SPV during mechanical ventilatory cycle is the sum of delta up and delta down. So as we see here, delta up plus delta down, that makes the systolic pressure variation, inspiratory phase minus expiratory phase. Slightly it is less reliable than delta down, and pulse pressure variation for predictive fluid responsiveness. PPV is the arterial pulse pressure variation during mechanical ventilatory cycle. PP max minus PP minimum divided by the average value multiplied by 100 gives you the pulse pressure variation in percentage. This is during inspiration. Then the expiratory phase, you get PP max, and you get, this is the PP max. This much is the PP max, and this is the PP minimum. 12% is the threshold. It has shown as a sensitivity of 90%. It has demonstrated the best predictive value with regard to fluid responsiveness in mechanically ventilated patients. Just like delta down, PPV is also considered as the best hemodynamic monitor. Stroke volume variation, SV max minus SV minimum. This is the SV max, this is the minimum. During expiration, divided by average, multiply by 100. And needs dedicated monitors like Litco-Pico using a pulse contour analysis algorithm. It is less accurate than the others. Peak aortic blood flow velocity variation, BPK max minus minimum divided by average, multiply 100, needs transesophageal echo. Here we see, this is the aortic flow. And respiratory variations in delta VP determine the fluid responsiveness. See, we can appreciate these respiratory variations in the aortic flow, blood flow velocity in a probable and non-probable responder, or a probable non-responder. In a responder, we see here, this was the variations, respiratory variations, okay, in pre-infusion, and after infusion, they are almost blunted. So the SVI here was a more than 50%, and so we can accept that this was a fluid responder. Here we see the respiratory variations are not much, and so post-infusion there is not much appreciable change. It is less than 15%, so it's a non-responder. This chart shows same PP max and SV max, and I think it's plotted against the airway cycle. So this is the inspiration, the expiration, and the blood pulmonary transit time. We have already discussed this. We can skip these. So why PPV is better predictor than the stroke volume derived variables? Other, inspiratory increase in pleural pressure leads to increase in extramural pressure, right? So this leads to equal increase in systolic pressure and diastolic pressure, right? So the increase in systolic pressure variation can be seen with equal increase in systolic pressure and diastolic pressure, but isolatedly there will be increase in systolic pressure, but since there is an equal increase in diastolic pressure, there won't be change in the pulse pressure variation. Clear? There is an inspiratory increase in pleural pressure, increase in extramural pressure, equal increase in systolic or diastolic pressure. Increase in systolic pressure will lead to increase in systolic pressure variation. But since there is also increase in diastolic pressure, there would be change in PPV unless until the patient is hypovolemic. In hypovolemic, these will be exaggerated. So that exaggeration will be reflected as fluid responsiveness. That exaggeration we can interpret as fluid responsiveness. There we can get an appreciable change in pulse pressure variation. What are the limitations? In cardiac rhythm is regular, arterial pressure, stroke volume, aortic flow vary beat to beat, and it is impossible to measure the respiratory variation if the cardiac rhythm is irregular. So that is a limitation. The patient is spontaneously breathing, pressure gradients are altered, and ventilation-derived indices become unreliable in predicting fluid responsiveness. Majority of studies use a tidal volume of 8 ml per kg. Differences in tidal volume can affect the predictivity and threshold of the indices. So finally, clinical conditions like RV failure, in spite of an enhanced delta down, stroke volume cannot be increased by fluid infusion because the RV is already failing. So there also it is a limitation. And noradrenaline infusion can enhance the systolic pressure variation and pulse pressure variation independently from volemic state. So that is also a limitation. Thank you very much.